Good morning and welcome to our Caring for the Caregiver seminar today on behavioral issues with dementia. We're so grateful to have you join us for this presentation. And I would like to start by thanking our partners who help us put these webinars on, and that is Sutter Health. So thank you so much, Sutter Health, for helping us continue to educate the community on such important information. Our speaker today, her name is Karen, and Karen's going to introduce herself in just a moment, but she's our clinical educator here at Community Hospice and has helped us with several of our other topics as well and does a great job, and it's just a wealth of information and resources for our community. So we're very grateful for Karen to be joining us today. I would like to remind you that we are recording this presentation and it will be available on our Community Hospice YouTube channel. Just go to YouTube, enter Community Hospice into the search bar, and you'll see this presentation as well as many other presentations on various topics. So you're welcome to share that with your family and friends or anybody that you think might benefit from this presentation. If you have any questions throughout the presentation, this is a collaborative meeting. We would love to hear your voices. So please feel free to unmute yourself and ask the question. If you feel more comfortable just entering your question into the chat box, that is okay as well. I'll be monitoring that and we'll be happy to ask those questions to Karen. So with that, again, Karen, thank you so much for joining us today and spending time with us. And I will let you introduce yourself and take over from here.
Thank you, Kristen, so much. Thank you, everybody, for having me. It's always a pleasure to participate and do some of these meetings and teachings with you guys. My name is Karen Desi. I am the clinical educator here at Community Hospice. I've been a registered nurse for 9 years with them, probably a registered nurse for 15 overall. So in hospice, behavioral health and dementia kind of go hand in hand. These are things that we experience quite often. And as a caregiver, these are certainly things that we come across quite frequently when we're caring for our loved ones, especially if they have dementia or Alzheimer's or a disease process that might take them along this path. And you might experience some of these behaviors even though your loved one is not diagnosed with dementia directly, but a type of dementia may occur during the disease process. So hopefully you'll find this education helpful and useful. And so again, like Kristen said, very, very open. This is so much better when you have lots of questions and we have back and forth. So feel free if you have questions or concerns to interrupt and ask those questions. I'm happy to answer them. I'll walk you through these. Some of the content might be a little heavy, but I'll try to make it as easy to follow as I possibly can. Okay? Thank you so much. So moving forward, some of our objectives today are just to learn at least 3 steps when trying to overcome behavioral issues with patients that have dementia, describing a positive response to an aggressive patient, and then you don't have to, but at least we'll give you 6 interventions to try when a patient is wandering. So some of the causes of behavioral changes can be that they have our patients, our loved ones, and sometimes even within ourselves. We have some physical discomfort. It may be due to illness. It may be due to medications. It may be due to our environment. It could be that the noise is louder than normal. The environment itself is too bright, or just it's a change of environment altogether. So new places can cause changes in behavior, the inability to recognize your home when we're put outside of our normal environment, things that we're familiar with, that can certainly cause our behaviors to change because we feel insecure or we're feeling lost and nothing looks familiar to us. If we are asked to do complicated tasks, having multiple steps to take can be confusing, and that can cause agitation, and that in turn cause behavioral changes. And we can often have short attention spans, which there again, if we have multiple steps to take, that can change our behavior as well. The inability to communicate. So patients that have vascular dementia, if anybody you know or your loved one has been diagnosed with vascular dementia, or someone that has had a stroke, that can definitely change the way that we communicate, either verbally or in writing or in any other form. And sometimes when we are trying to have the conversation, the words we're trying to form don't come out correctly, and that can certainly cause us to have changes in our behavior as well. I'm usually soft-spoken, so I apologize if you don't hear. Just, raise your hand, tell me to speak up. I'll try and keep it loud. Okay, so here are our 3 steps to approach to help overcome some of these behavior issues. 1, we want to identify and examine the behavior. What is the behavior that's being exhibited? Is the behavior harmful to anybody, either to the patient themselves or to the people that are taking care of them, or anybody surrounding that area? What happened before the behavior started? What happened immediately after the behavior happened? And then consider some of the causes that were related to either medications or illnesses. And all of these things are really important to consider because they're normally outside of the normal behavior of our loved one that we're caring for, right? It's not the way they usually behave. And so we really want to be mindful. We don't want a reproduction of this, to be mindful of what was the cause, what happened, how did it affect the person that we love and we're trying to take care of, and how are we going to remedy this? So then we're going to explore potential solutions, right? We are going to look at meeting the basic needs of the patients. Have they gone out to the bathroom recently? Have they eaten? Has it been a long while since they've had a meal or had fluids? Did we just put them in a new environment? So are they having to try and adapt to the surroundings, and then changing your reaction or approach to the person? There are times when our loved ones may be in the same environment all of the time. However, the way that we walked into the room or the lighting or their perception may just be a little bit different. So if they reached out to grab something and we went to help them and they didn't feel that they needed that help, they may be a little bit more aggressive than usual. The way we respond to that behavior also is going to affect how they respond back to us. So love begets love, kindness begets kindness most of the time, and aggression usually begets aggression. So we just want to be mindful of how we respond. And sometimes it can be difficult, especially when we're tired. And then trying different responses. Evaluate the person's response to your new approach, not to your previous one, but to your new approach, and explore other potential causes and solutions. So if that worked, great. If it didn't work, what can I do differently to try and pacify this behavior? Any questions, thoughts, or concerns so far? Okay, moving forward. So some general tips that might be helpful. We want to try and alleviate any pressure on either side of the fence, right? We want to keep the patient as calm as possible. We want to be able to have a really good relationship and be able to do this easily as well. So we want to maintain a routine. And if we do have caregivers that come in and care for our loved one, then we want to teach them what those routines are so they're familiar and we don't disrupt anything that the patient is familiar with having. We use control movements, so no sudden flailing of the arms or even when we're making a bed or anything, no shaking of the sheets. So anything that's exaggerated can cause some agitation. So we want to keep everything calm with gentle tones. We want to use short sentences. I'm long-winded, so I can attest. Sometimes people's eyes will roll to the back of their heads because they're like, are you done yet? Short and sweet is usually the answer here. You just want to use 1 or 2 words that are going to express what you need or what you need of the person that you're caring for. You want to stay at eye level. It makes a tremendous difference in the perception of the person we're caring for when we're over them, beneath them, or when we're at the same level as they are. That's so much more respectful and gentle and kind and we want to treat them the way that we want to be treated, right? There's no deflection of authority or anything if you're at eye level. Minimizing noises and distractions. If they're used to quiet, we want to keep it quiet. When there are sudden noises in the background or lights or flashing things that we're doing for decorative reasons, it can be a huge distraction, and it can also trigger different things in a patient that has dementia or is on medications that might alter their behavior, that can really trigger them. And so we want to just keep those to a minimum. Age-appropriate music is always helpful because it's very familiar. And when we say age-appropriate, it's not that we're thinking someone's 70 years old, so they have to have mellow music, but age-appropriate to their era is sometimes very helpful and very familiar, and it kind of keeps everything very calm for them. And always having a happy, reassuring attitude. Don't have to be false with the way that we behave, but we do want them to feel that they are loved and cherished and important. And so we want to always keep an upbeat attitude because we don't know where their mindset is. And often if you're bedbound or restricted in any way, it can be depressing and saddening and disheartening. And so we want to keep that attitude as relaxed and easy as possible. Any questions, thoughts, or concerns? Okay. Diversions. So we've tried all these tactics. We've tried to keep the routine. We've triggered something anyway. How are we going to now distract this person's behavior? Some really good tools are photo albums. If you can't get them to focus on anything else, looking back at old memories usually helps really well. Distracting by singing an old familiar song or just a familiar song. It doesn't even have to be old, but something that they're familiar with that they can sing along with that really resonates with them. Reciting a pro, past hobbies, talking about them, indulging them, helping them with it. Even if that means just playing cards or go fish or something that they're familiar with that they can participate in that would take their mind off whatever it was that triggered them to have a behavioral issue. Reading large print books really helps because as we get older or as our disease processes progress, often our eyesight is also affected, and trying to read tiny little print makes it really difficult. So we want to try and give them something that's easy for them to read, for us to read. Sometimes I find that I need some help in that aspect too. Have a comment. Rita says, photo album for mom always calmed her down and diverted from a stressful situation. Thank you for that. Oops. Okay, so how do we deal with the aggressive person? Okay, we really have to take a good look around ourselves, right? We want to evaluate the environment. Did we have a lot of noise? Sometimes the noise is construction and there's not a lot we can do, but closing windows and just putting on gentle music inside can sometimes distract from the over active noise from outside. But if it's internal because the TV is blaring or there's a lot of electronic noise going on, that is something that we can try and tone down as well. Overactive environment. If there's a lot of hub going on, a lot of social interaction with other people, a lot of noise comes along with that, dishes clanging when we're cooking, want to taper that down a little bit. And then of course, physical clutter. If the environment is cluttered and has a lot of things around it, can feel claustrophobic. It can cause somebody else to feel like they need to deal with it, but it can become very overwhelming and cause someone to become aggressive or have a behavioral disorder, behavioral change. Poor communication. If we ask too many questions, and I can be honest and say I have been guilty of doing this, too many questions, too frequently, too quickly, or making too many statements, asking for too much from a person that has to process things at a slower rate, and then rapid fire questions. will also cause agitation and behavioral changes as well. Our response should be what happened before the reaction, right? We really want to evaluate that and then respond to that. Focus on the feelings and not the facts. The facts might be there wasn't that much of a change. However, someone is feeling unsafe, ridiculed, unhappy, angry, whatever that looks like. And we want to focus on why are we feeling this way? Maybe they're able to tell us. Sometimes that behavior can really be harsh to the person that's trying to do the good thing, the right thing, the helpful thing. And so we don't want to get angry, upset, as aggravating as that can be, because we can't nail down what the problem is. They can't express themselves. We're able to walk away from this. And sometimes we need to, right? So we are going to limit the distractions. We're going to try and work on doing relaxing activities, shifting the focus again, using all those divertive techniques. And sometimes, if it is safe to do so, walking out of the room, taking a 10-second break, and walking back into the room can change everything. So that's an option too. Preventing or reducing agitation, again, it's all about keeping things calm and a safe environment. Of course, then there'll be that one occasion where they are agitated because you're too calm and you don't, there's not enough noise because they feel like they're in this crazy little lull. And so you would adjust your behavior and attitude at that point in time. But 99.9% of the time, we want to keep a calm, safe environment. We want to avoid triggers that we are aware of. We want to monitor patient comfort, make sure that if they're having pain, that we're treating for pain. If they have a sleep disorder, that we're helping with the sleep disorder. If they have other triggering factors that cause them to be agitated, temperature, too cold, too hot, blankets that are too heavy, we want to make those changes and make the patient as comfortable as possible. Simplifying tasks and routines. If they're able to get up and get about and they'd like to give themselves a shower or a bed bath or even a comfort bath, we want to try and get things in order for them so that the task is easy and not overwhelming for them. If they don't want you to help, as long as they are safe, sitting or standing and you're close by, it's okay to let them try and do it themselves, and only offer help once in a while. If we ask too many times, that causes agitation, and the chances of that loved one falling is going to be greater. So we want to be close by, hovering, but not so in their face if they are just needing a little space. Triggers, change of caregivers can be a trigger. You're usually familiar with the person that has been taking care of them. They've been trained well. They know everything that's familiar with them. And now suddenly there's a new face, a new attitude, a new touch, and that can cause some aggravation. Change in living arrangements. Certainly the change in environment is a huge aspect that can cause agitation. Traveling, even though the person may have wanted to travel, it takes such a huge toll on their body, on their mind. It's a lot of stimulation, and so that can cause some agitation. Hospitalizations can certainly, again, it's another environmental factor. It's a change in caregivers, it's change in routines and habits, and so that can definitely cause agitation. Bathing, again, they have their routine, and if it's a switch from what they're normally used to doing, as loved ones get older, and my mother-in-law, who is baptized and has this routine, she has to shower every single day, and on the days that she is feeling down and she's not able to, or she just doesn't have the whereabouts to even allow me to get her into the shower or into the bathroom, she will refuse her bed bath. She will not allow for anything, but she will be as aggressive and as agitated as possible until the next time she's feeling strong enough to get into that shower. So those routines are really important and sacred to people, and it can cause some discomfort. Do the best that you can, offer all the options that they have, give them every tool that you have. They can pick one or not, and that is their choice. Not everything is your fault. Sometimes it's just the way things fall. And then changing clothes can be difficult. So again, offer support, offer help, offer just help them pick something out, because picking out clothes can be overwhelming as well. So, give them a couple of options, not so many that it becomes overwhelming, but this one, oh, this one, you like this one better? Okay, would you like some help? No, I can do it myself. Step back a little bit as long as they're safe. When they are struggling, you can offer again, and they will take your help usually. Your response to some of these things is to listen to the patient's frustration. That's all we need to do sometimes, is listen. We don't always have to have an answer or a solution. Provide reassurance. Involve the patient in activities. Modify the environment. Find some outlets for energy, because often they have a lot. And then just check yourself. Just take a moment, breathe. Make sure that you are also in control of yourself, even though you may feel a little bit out of control. I know for myself, I find that when my mother-in-law is agitated, and I've helped, and then I become agitated because nothing is working, and then I have to give myself a little time out, because I'm not helping the situation, I'm just making it worse. So just, a little time out, just to make sure that we are all on the same page again. Also put, we have to realize we get agitated when some of these things happen, and agitation multiplied for those with dementia. Absolutely. Thanks, Rita, for participating. So going on from being agitated to the confused person, again, we are the ones that have to kind of keep the environment and a handle on things. So we want to stay calm. Use brief explanations, show photos and other reminders, and offer corrections and suggestions, but not telling them what to do. We're just offering. Like this or like this. Is this correct or like this? We don't want to confuse them more, so we just give them very limited options, but just redirecting them. Some patients can have hallucinations. And when they do, we want to really be mindful of a few things. We want to offer reassurance. I used to have a patient who would say, that Don dog is in the corner again. Well, he could see the dog. I couldn't see the dog. But we're like, oh, is he bothering you? No. Do you want us to tell him to go out? He's fine in the corner. Okay, so we're all good. And then we'd say, hey, we were going to have a meal. Let's do this. You were going to eat food. Should we get it ready for you? And that would distract him enough. There were other times that he was just like, get this dog out of my room. The dog shouldn't be in the house. And sometimes would help shoo, and sometimes would be like, it's really cold outside. Oh, well, then we shouldn't. If it's raining, they should stay inside. So it helps. We don't want to solidify the thing, but they are obviously seeing something that we are not able to participate in. We don't want to be argumentative. We don't want them to feel like they're not telling the truth, because in their mind's eye, they really see all of these different things. And so we just want to direct them in a different path. If it's something that is causing them to be fearful, it's causing them to not be able to function well, this is a time we might want to seek out medical help, okay? But we can use other distractions like walking, going into another room, using music, and doing other activities. Sometimes we'll play ball with him for a little while just to get him distracted, and then modifying the environment. They may be misinterpreting noises or shadows or mirrors, and so changing the lighting, opening the curtains, the blinds sometimes shed some shadows, and so just pulling the blinds up when in that late afternoon area that was just causing shadows to fall in a different direction. That was helpful to him. Teresa's so true. all of these, it does make you feel like it's as though we're dealing with young children at many parallels. And so you have to be that calming adult figure for them. That's a very true statement. Sometimes our patients will repeat words and phrases and motions. We just need to know what the reasons are behind that repeating. Alzheimer's patients, this is just a part of their mechanism. They repeat the same words. They're not able to necessarily find other words to use. So they may just, rock and say, help me, help me, help me, help me, help me all day long. But there's, no matter how much distraction techniques you use, no matter how many other things you do, they come back to that same choice of words. But we want to focus on the emotion and not so much on the behavior. So let's see what it is that they may need help with. Are they looking like they're fearful? Is it dinner time? Is it lunchtime? Is it time for their bath? Are they needing to be changed? Have they been to the bathroom? We want to make sure that they are as comfortable as possible, and the behavior might be a response to something that needs to be changed, or it just might be who they have become at this point in time, and there's no changing that. Turn the action behavior into an activity. The busier they are, the less they have the ability to keep being focused on that behavior. Always be calm and reassuring. Never want our loved ones or our patients to ever feel that they're in danger or have any insecurities within our control. Provide an answer if you have one. Engage person in activities if they're bored, because sometimes the repetitiveness is just out of boredom. Use memory aids, and then accept the behavior. If there's no changing it, that's an okay thing, because that just might be how the person is. Singing is always an activity that most people connect with, love, and can be distracted by. And even those that are repeating the same word over and over and over and over can often find themselves engaging in songs and pick up the lyrics. Sundowners is something that happens more often than not. And sundowners is, as it says, it's kind of when the sun starts to go down, but it usually happens a couple of hours before that. As the day is cooling off and the shadows are starting to fall, the sundowners' confusion is starting to take place. It can be agitation, it could be needing to sleep more or sleep less, or suddenly they are a burst of energy. And so, we really have to start planning when our loved ones or patients start to develop those types of symptoms or having sundowners. We want to plan more day activities. We'll tie them out by the time that 3 o'clock time comes by. We want to monitor diets, no caffeine late in the day, any physical ailments that they may have. We want to do activities that are not going to impinge on any of those, but those physical ailments sometimes get worse during that sundowners time. So we want to make sure that we are treating those accordingly. Changing in sleep arrangements. If we're changing their environment, if we're changing the lighting, if we're changing even the scent in a room, can cause some disruption. And so we want to make sure that we keep to those routines that are even keel for them and not causing disruptions for them at all. Always using that calm approach. Address any needs that they have. We want to avoid arguing, and we want to offer reassurance. For hospice patients that often experience sundowners, we really highly recommend that start to turn down early, right around 3-4 o'clock in the afternoon, depending on the time of the year. We want to make sure that we're not running the washing machines or the dishwashers. We're starting to turn down the lighting a little bit. We're just making a really calm environment. The TV's turned down. In an environment that we possibly can do those types of things, so that there's a calmer environment and they are not agitated by any of the things that are going on around them. Some causes are from exhaustion. Most of them are caused by an upset internal clock. Reduced lighting can increase shadows, and that can cause some confusion and disorientation. Some disorientation can be that they took a nap and they've woken up and they're still in that dream state and they cannot separate that dream from reality. So again, we really need to be reassuring and comforting for them at that point in time. And then decreased need for sleep occurs when patients have sundowners. Suddenly they have this burst of energy which can keep on going until midnight, but you don't have that much energy. So that's something really we want to look at medically, if there is a treatment for that, if all the other exercises and treatments and activities have not helped, then it might be time to go seek medical help and see, hey, look, I can't stay up until 2, 3 o'clock in the morning every day. We need to help them be comfortable. It could be pain. It could be just that they don't have a need, but then we want to make sure that we're not encouraging sleep during the daytime hours. We want to keep them awake as much as possible so that they are able to sleep. We want to reset that internal clock so they're sleeping at the right hours. Questions, thoughts, or concerns so far? Okay, so often with sundowners and patients with dementias, you're going to have patients that are very suspicious. Okay, it's not their fault. This is just a part that is triggered inside their minds, and they are becoming distrusting. And we don't want to take offense. We want to listen and reassure. We certainly don't want to argue. We want to keep our answers simple. Switch the focus to another activity if possible. And if it is at all possible, we want to duplicate those lost items. Okay. Often people remember things that were there that haven't been around for a really long time, but something has triggered a memory and they are missing this thing that was very valuable to them. And so we want to try and keep them at ease as much as possible. And so if it's possible to duplicate those items, we want to try and do just that. We also have those patients that wander. So some tips to try and keep them from wandering are to encourage movement and exercise as much as possible. One, if they are able to get up, use their walker, or just use a cane or need standby assistance, we want to make sure that every activity they do is always safe. And so stay by their side if that's possible to do. Allow them to enjoy the outdoors if that's a possibility. Ensure all basic needs are met. Sometimes they're wandering because they feel like they need to go to the bathroom, but they're not able to verbalize it. And so they're wandering for that reason. So we want to make sure that those needs are met. Involve the person in daily activities. And sometimes engagement can be difficult, but we want to find an activity that they really enjoy and that will keep them occupied for some period of time, whether that is painting or stitching or folding or walking or playing cards or charades, whatever that looks like. We want to keep them active in that part. Place color matching clothing over doorknobs. That way they can't see the doorknob and they don't try to attempt to get out. We want to redirect behavior as much as possible. Placing a mirror near the doorway, they reflect themselves and they see other people. So that's a good way to distract them, as long as it's safe and it doesn't, impinge them in any way. And there's no chance of them pulling at the mirror and knocking it over. So that's definitely an option. And reassure the person if they are feeling lost or abandoned. We always want them to feel safe. And so it's okay. I'm with you. Where do you want to go? And often it's, I want to see my mom. And we know they no longer have a mom. But in their mind's eye, they feel like they need to have their mom. And so all we can do is say, well, where did your mom live? Well, what is happening? And just go along with that and just give them a sense of reassurance. And so they don't feel like they're abandoned and lost. Sometimes reality makes it worse rather than better for them. And we do not want to trigger an even harsher reaction. Excuse me. Medications that can make dementia symptoms worse. So it's really important to really be mindful of what medications the patients are on. And if the physician has asked, hey, we're going to trial this medication for this length of time, this is how this medication works, and these are some of the side effects the patient may have, let me know. We want to really be diligent about making sure that we're monitoring what the responses and the reactions are to each of the new medications that the loved one's having. If they are having increased agitation or confusion, that's something we want to document. Did it happen the first day, second day, third day, fourth day? Has it been continuous? Have we seen any changes? And if there's no changes within a day or two, that's something we might want to communicate to the physician and let them know that this may not be working. One of the best questions possibly is to ask, how long will it take to take effect? What should I be looking for if we don't get those educational symptoms ahead of time? Just what should I be looking for? What changes could occur? What are possible side effects? A lot of medications that patients take can cause them to have dry mouth, can cause constipation and difficulty urinating. And if you're seeing those things occur within your loved one or your patients, then we definitely want to reach out to the physician and say, hey, this is becoming worse. How can we help them? Because we might need to give them medication for constipation. We might need to change the dose. We might need to give them an additional medication to help them to urinate easily and not have that difficulty. We don't want someone to feel like they have to urinate all of the time. That's another cause and another issue that can cause increased agitation, but also possible falls, causes wandering, can cause complications with confusion and other disease processes like having a urinary tract infection. So we just have to be really mindful of any medications that they're taking and what reactions people are having to them. Just a whole list of more. When considering the use of medications, it's important to understand that no drugs are specifically approved by the FDA to treat behavioral and psychiatric dementia symptoms. We trial a lot of different medications to help modify some of those behaviors. And so when we do that, again, just as I said, we really have to be mindful and watch for any side effects that the patient may be experiencing. So we're going to skip through a lot of these medications because they're heavy. Your physician or nurse may recommend the most effective medications, especially if you have a home health nurse or a hospice nurse. They would be able to come and sit down and really look over those medications and help with determining what the symptoms are and if they are side effects to medications that they happen to be on, or if they're just part of a comorbidity that the patient has, and when to reach out to the doctor. Residone is a very common medication that we give to patients that have trouble sleeping at night, and can also help to increase appetite during the daytime. So if we have loved ones or patients that are having issues with their appetite and not really feeling hungry, but also have either sundowners or just insomnia, this is a really good medication that we often will help the patient to sleep well, have good appetite during the daytime, and earlier in the daytime give them some level of alertness that they may not have typically because they're so fatigued from not sleeping the night before and not having a good appetite. Peridol is a medication that hospice uses quite often. It's used for patients with sundowners, and we use it again, just as I talked about, often when the sundowner time happens. So we start giving the medication right around that 3-4 o'clock time frame, and depending on the level of sundowners patients have, it can be given every 4 hours until they fall asleep, until we get that internal clock back to where it needs to be so that they are sleeping through the night, and then they progressively need less and less of that medication. Of course, we want to give that medication as ordered. We want to keep the noise levels down and the lights low. The TV should not be blaring next to them, and this medication can help with nausea, vomiting, agitation, and combativeness. So it's a really, really good multi-dimensional medication that can help with different symptoms depending on what they are. So they don't have to take multiple medications if they are having any of these symptoms. That one medication will cover them all. Seroquel is another one that is used quite often, especially in facilities. This medication can help with behaviors such as agitation or just being uncooperative, and the digging that usually helps to prevent that kind of behavior. Just to keep in mind that every patient is different, and so please remember that not all patients will respond in the same way to each of these medications, and some will have some side effects and effects of the medications that will act quickly, and some will have delayed responses to those medications, and some may need different doses. So it's always just kind of a balancing act with these medications. But again, we want to take note and report to the physician what we're seeing so that they can make the appropriate adjustments to the medications. We want to always be kind when providing care of any kind to any patient, especially our patients with dementia or behavioral issues. How to treat some dementia symptoms? The following are some therapeutic techniques that we can use to reduce agitation and promote relaxation in people with dementia. Music therapy usually works amazingly. I have had patients flailing their arms and trying to get out of bed, and you put on some gentle music. And for some patients, some, music from their era, and that's a little bit louder with a little more bounce to it. And they are just moving to that, and it just seems to soothe them right down. Helping with them just do some light exercise, just getting that energy out really helps. Watching videos of family members. Pet therapy is a really great one. If you have pets in the home and they like the pets, definitely pet therapy works great. Aromatherapy can be useful. Massage therapy, if they're able to tolerate it. Art therapy and folding clothes. That's usually one that we use a lot just to keep their hands busy when they're picking or pulling and doing different things like that. Other coping tips, we can monitor personal discomfort, avoid being confrontational or argumentative about facts, because what we know as facts and what they know as facts might be completely different. Redirecting the person's attention, create a calm environment, allow adequate rest between stimulating events, because they need a little downtime. Recovery can be really hard when we have all of these different things going on, especially as we get older and our minds aren't as sharp and need more time to rest. I know from myself, even the 20 minutes it takes to get home, sometimes I just need some downtime from having all that stimulation on the road. So provide a security object. Some people you will see have a little teddy bear, a blanket, something that keeps them holding on to something that will just make them feel like I am safe. Acknowledge requests and respond to them, right? We just want to be like, oh, okay, you need some water, but then never give them water. We want to say, oh, okay, I will go get it and bring it back to them. And at a reasonable time frame, right? If we're thirsty, we want to have that drink now, not 6 hours from now. And that will help to really alleviate a lot of the stresses that happen, the change in the behavior, the confusion, the agitation, the wandering, and they'll be so much calmer sooner. Look for reasons behind each behavior and then explore the various solutions that we've talked about in this talk. So in conclusion, use the three-step method, create a secure environment, and then that will lead to a better quality of life. Any questions or concerns?
Karen, thank you so much for all the wonderful information. I'm going to open it up now for any questions or concerns. There is something that was shared. It said, my friend shared this acronym as her mantra. She cares for her mom with memory issues. C-A-R-E, care. Don't argue, don't reason, don't explain, just care.
That's really thoughtful and loving of that person. Also resets ourselves internally. So I'll take that home with me.
Any other comments or questions for Karen at this time? Mom found comfort in her rosary. Absolutely. Would you mind moving your slide to the next one for me, please?
Absolutely.
All right. So if there's no further questions or comments, I think there is actually one more. It says, thank you for the very thorough explanation. I love your mantra, kindness, I think it's kindness, etc. Mom found comfort in her rosary. Thank you. Extremely informative information. So I think we all are on the same page when we thank you for spending your time today and sharing your wisdom. At this time, I would like to just go ahead and remind you that we do offer this webinar once a month on various topics. Next month, we'll be joining our speaker on November the 11th at 11 o'clock, same time. You can use the same link that you used with the passcode, and that topic will be coping with the holidays. We are getting ready to approach the holidays here, Thanksgiving, Christmas, and New Year's, and sometimes that can be difficult when you experience some type of loss in your life. And so I'm sure our presenter will present a lot of great resources on how to cope with the holidays and move forward and memorialize a loved one and go from there. So again, we hope you join us next month, November the 11th at 11 o'clock. Again, it's virtual. This presentation, again, is also recorded and will be available on our YouTube channel later this afternoon. So with that, I just would like to, again, thank you everybody for joining us, and I hope that you all stay safe and well. And Karen, have a lovely day.
Thank you. Thank you all. Guys, take care.
Bye-bye.